Hello, welcome. This is Faisal Hassan, your member of Provincial Parliament, and tonight here we are gathered doctors and experts town hall meeting on vaccination discussions. First, I would like to acknowledge at this time the land that we now know as York Southwestern is a traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuits, Métis people. And folks who are joining us Facebook Live, Faisal Hassan, ndb.com. Tonight we had a bit challenging technicalities with YouTube and Twitter, but next time we'll be able to connect to you live there. Thank you for joining me for this important town hall. As you know, our community has been particularly hard hit by COVID-19. We have seen a disproportionate number of cases in York Southwestern, and we are very eager to put this historic pandemic behind us. But as the vaccine rollout progresses, residents are taking in a lot of information, resulting in questions about safety, efficiency, and time of vaccine availability. For this reason, I have invited a panel of experts to answer your questions and provide some clarity to the members of our community. And I have distinguished experts. Sabina Vohra-Miller is a founder of An Ambiguous Science and the co-founder of the South Asian Health Network. And also Dr. Naheed Dosani is a palliative care physician, Department of Medicine, St. Michael's Hospital at Unity Health, Toronto. And also we have here Sudha Kutty, Vice President, Strategy and External Relations, Humber River Hospital, right here, our neighboring riding of York Centre. And also Dr. Zainab Abdurrahman, McMaster Children's Hospital Allergy Lead in the Special Immunization Clinic focusing on vaccine allergy. And Dr. David Burt is president of the Burt and Research Consulting, offering independent counseling advice in vaccine and biologics research and development. And also here we have also Dr. Akwatu Khenti, Special Advisor to the City of Toronto, Chair of the Black Scientist Task Force in Vaccine Equity. And also finally, we have Domenico Calla, Manager of the COVID-19 Community Engagement Outreach Team at the Toronto Public Health here in the City of Toronto. I welcome you, all of you, for joining us tonight. I would like, before we have got also some questions already registered by members of the community, but before we go into the questions, I would like to welcome each and everyone to give maybe 2 minutes of introduction before we start the discussions.
So, why don't we start in alphabetical order?
Yes.
Or, Domenico, we can start with age. All right,
Well,
I'll just kidding. I'll start and we can put on. Yeah. Okay.
Go ahead, you start. Yeah.
3 points. 3 points I think is very important, but just by way of introduction and context. One is that COVID-19 is a threat to all Canadians, a significant threat. The mortality rate is 16 per 100,000 for Canadians as a whole. But the threat to Black, Indigenous, and racialized Canadians is double that, 35 per 100,000 as a whole. That means you're twice as likely to die if you get COVID if you belong to a racialized group. That's a huge threat. That's a huge risk. And that threat is driven not by race, which is a socially constructed reality anyway. It's not driven by ethnic identity or anything related to one's own personality. It's driven primarily by the social determinants of health, driven by where you work, how much money you make, or actually how much money you don't make, the spaces that you inhabit, the transport that you use, whether it's public or private, and the stress you experience from systemic racism, which leads to a series of underlying conditions that COVID just loves: heart disease, diabetes, you name it. High blood pressure, I got it. Asthma, all conditions, chronic conditions that really are exacerbated by the systemic racism of the societies we live in. What drives that point home is the distinctions between the prevalence patterns we have in these societies of North America and Western Europe versus what we have in Sub-Saharan Africa, Latin America, and South Asia, which are huge. The disparities and the differences are huge. What do we have to do? Whatever we can to reduce the risk and enhance the protective factors. That's what this is about. Whatever you can do by way of prevention, you don't have a choice. If you want to look at, what's in the best interest of yourself, your family, your community, your society. And that's my opening. Thank you very much.
Very good. Thank you very much. And perhaps we can roll quickly. Maybe we can start Dr. David, and then we go to.
Hello, it's good to be with you all this evening. I've worked in the vaccine industry for over 30 years, and I believe in vaccines because I've seen how they're developed, how they're manufactured. And my concern has always been around vaccine hesitancy. The WHO says that vaccine hesitancy is one of the top 10 health crises in the world. And I'm particularly maybe appalled by some of the things that are being put in social media and really confusing individuals. And so one of my passions is really to try and give correct information about vaccines and COVID so that individuals can make informed decisions about vaccination.
Very good. And perhaps we could come to maybe Sudha Kutty, Humber Hospital.
Sure. Thank you, everyone. I'm so happy to be here tonight. So we have been vaccinating our community since the middle of December. We set up a vaccination clinic here at the hospital to have people come in and be vaccinated. And then we've also partnered that strategy with a mobile strategy where we've been going out to congregate settings, to faith communities, to naturally occurring retirement communities, to shelters. So really a multi-pronged strategy in partnership with the hospital as well as the community. Completely agree with everything that's been said, the importance of vaccination in this community in particular. And so we have been supporting that through any means we have. We are moving our vaccine clinic from our hospital on March 31st. We are moving to Downsview Arena at 1633 Wilson Avenue, a larger center that will allow us to vaccinate more people. And as of right this moment, we have slots still available for next Friday for vaccination at that center. So I would encourage everyone who is eligible to be vaccinated to come to that location right opposite Sheridan Mall, easily accessible by TTC, and just a larger space for vaccinations to occur.
Very well. Dr. Zainab Abdurrahman.
Thank you. Thanks for having me. I'll try to keep it brief. So I'm a clinical immunologist and allergist. And I'm part of the special immunization clinic. So I see patients with concerns about vaccine allergy, and this has been in place prior to the pandemic. What I do want to say is I've been working on a lot of accessibility and discussions about hesitancy related to the COVID-19 vaccines, especially in the context of racialized populations. I think Dr. Khenti had already discussed that we're not different in any way. There's no genetic factors, but it's actually just from the structural racism that's in place that puts certain populations at risk. And this is an opportunity, I think, for us to turn those tables around. So I really encourage you to reach out and ask your questions. My main focus has been to really address the issues that are coming up with education and safe spaces to discuss it. If you wanted to say, I'm concerned because, as an individual of a certain minority, I have seen transgressions against my race by, healthcare government systems. Okay, let's talk about that. And we can address that because we know what has happened and we know that there has been breaches of trust. And so we want to be here to answer your questions in a safe space and address any of your concerns. So that's why we're here today, and I'm happy to be part of this excellent group. Thank you.
Thank you, Dr. Zainab. Dr. Naheed, Dosani.
Hi, everyone. Thank you for that introduction, and welcome to everybody who's joining us today. It's an honor to join this group of inspiring panelists. I'm a physician. I actually work in the area of palliative medicine, where I spend a lot of time providing healthcare for people who experience vulnerabilities like poverty and homelessness. During the COVID-19 pandemic, I've also worked as the medical director of the Region of Peel's COVID-19 isolation and housing program, and I've worked publicly with my colleague Sabina, who joins me here today, as a health communicator, doing COVID-19 town halls and addressing vaccine hesitancy in racialized communities and communities where people have experienced loss, trauma, and pain, often at the hands of healthcare. And many of my colleagues have already spoken about it, but it goes without saying that education around vaccines are important, and we must be compassionate in these conversations. We cannot be dismissive. We must be clear about the science and the processes that were used to derive these vaccines, and we must be creative about how we are messaging this to particular communities. Events and discourse like this are examples of that. I think it goes without saying that many communities have a mistrust in government, in institutions, and in healthcare. And my hope is that in conversations like this, and the work that I've done with Sabina, who will be speaking soon, is to really build community and build relationships and build bridges, so we convert those feelings of mistrust into trustworthiness in the healthcare system. We're asking a lot of people to take on the COVID vaccine, given the hurt that people have experienced at the hands of healthcare, in healthcare, by healthcare. But we're here to discuss that. We're here to put it all on the table so we can come to a place of productivity, of strength, and to celebrate the resilience of this community and many others across Canada. It's a real pleasure to be here with you all today.
Well, thank you. I would also like to put in the record that in February 2018, Dr. Dosani received a Meritorious Service Cross for Humanitarian from Governor General. And Sabina?
Hi, thank you so much for having me here today. What an exceptional panel. So I will build on perhaps what Dr. Dosani has said. I've been countering the vaccine myths and disinformation on social media for several years now. I have a background in clinical pharmacology and toxicology, and that's really the reason why I have my science blog called Unambiguous Science, just breaking science down into easy to understand language for people to, without any politicization, without any sensational headlines, and really focusing on the 3 C's of vaccine hesitancy. So building confidence, and trying to counter complacency, and also in terms of convenience, making sure that there's access, especially built into our discussions, and making sure that the vaccine rollout is equitable. So I think that there is 3 main components to it. And because of this, we co-founded the South Asian Health Network, because we saw in Ontario that South Asians were disproportionately impacted by COVID. And we know that this is due to structural barriers that exist and not because of Diwali parties. And so we created this essentially, to try and bridge the gap and meet people where they are, to give them information in languages that they understand and formats and mediums that they consume. And we've also been doing a lot of vaccine education through this. Thank you for having me.
Thank you, Sabina. And finally, we come to Domenico Calla.
Hello, everyone. I'm from Toronto Public Health, and I'm here to talk to you about the complex world of who gets vaccinated, when they get vaccinated, and where you can go to get vaccinated. Many different options, and that can be very confusing, especially if there's some inconsistencies depending on the site in which you go. So I'm going to be happy to answer those questions to the best of my ability. It's complicated. I hope to simplify it for you.
Well, thank you, neighbors and friends. Tonight we have distinguished panel to talk about vaccinations. And I know that some of you have already registered questions, and I welcome all of you who are joining us Facebook. I see your comments, I see your questions, but first I want to start those who have already registered. And if we have enough time, then we'll be able to include your questions as they come first to the last. The first question we have that have registered comes from Charity Smith, and she has asked, will the vaccine work on people with asthma and COPD? Anyone could take that question.
Sure, I'm happy to take that question. Actually those with asthma and COPD, specifically COPD, has been a bit of a risk factor in terms of a lot of negative consequences when getting COVID-19. And when they did the studies, those diseases were included, and there was still evidence of efficacy in terms of how well it worked. It still works in those patients. And in particular, we were all paying attention to those populations due to their higher risk, specifically the COPD. So yes, all of the vaccines that are currently available do work in populations or in people who have asthma and or COPD. So any one of them would be appropriate if when you're eligible for a vaccine. If anyone else wants to comment as well.
Absolutely. If not, we go to the next question, and just a bit long comment. I'll just read. It says, everyone is skipping around childcare workers. Are we not a part of the education system that caters for child development in providing for their cognitive, physical, and social and communication skills that helps elevate or propelling them for school-based readiness in terms of vaccinations? Our names are at the bottom, although we are treated as frontline workers. Where is our turn for vaccinations? And it comes from Denise. So that's a question, maybe Domenico might be able to answer that.
Yes, yes. Thanks for your question, Denise. And I totally agree with you that childcare workers are essential. And, you know, the work is very important. You help educate and prepare our children for the future. I will say that childcare workers are part of the phase 2 of the vaccine sequence and will be eligible for vaccine at the beginning of June. The province is the one that sets the priorities in terms of age and occupations and different risk factors. And the province has gone through an ethical framework to determine when very limited supply of vaccine. The supply is increasing, but still limited, who it needs to go to first based on risk factors such as age, you know, the healthcare workers, residents in seniors' homes. So those particular groups have been put first in the prioritization, but childcare workers, your time will come and in first 2 weeks of June.
Very good. Well, thank you. And I think Charity Smith says, thank you for your answer. And we'll keep going. And I think David here asked a question, says, vaccines, which to choose from?
Since I've got the same name, I will answer.
Okay. That's great. David, Dr. David, yeah, go ahead.
Okay. Well, I think at the moment, we haven't got much of a choice. And it's probably a good reason, it's a good thing to not have a good choice, because really all of these vaccines protect against severe COVID and against hospitalization. And that's what you want a vaccine to do. You don't want people to get very sick, to end up in hospital and on a respirator. So all of these vaccines are effective in that way. I know it's tempting to look at one vaccine that is supposed to be 95% effective and another that's 70% effective, but you also have to recognize that these vaccines, the clinical studies were performed at different times, and some of them were performed when there weren't many variants around. So others that were performed later, when variants around, may not have worked as effectively against those variants, but all of them, even against the most feared variant, which is the South African variant, all of the vaccines will protect against severe COVID and hospitalization. So really, the choice is easy. We don't have to choose. Whichever vaccine is available should be the one that you take.
Very good. Anyone wants to comment there?
I wouldn't mind adding maybe just one little small point as well. I completely agree with Dr. Burt. I also think that sometimes people get really fixated on numbers, and actually what people should be looking at is the fact that, you know, the primary efficacy endpoints were not the same across all the board in all the clinical trials. So it's really, you know, look at it, they were looking at apples versus oranges, right? What was across the board similar is, you know, whether someone was hospitalized, or someone died due to COVID. That we know yes or no, right? And in that situation, across the board with all 4 vaccines, there, you know, we saw almost nearly 100% across the board for all vaccines. So each and every one of them gives you that, you know, exceptional protection against severe disease, against, you know, hospitalization, against being on a ventilator, against being in an ICU. And I think that really is the take-home message. I think that getting lost in these numbers, you know, is not very helpful. And, you know, I think it goes back to this analogy that one of my friends, Dr. Abdu Sharkawi, said to me, you know, one of our town halls, is that, you know, you're out in the cold and you're naked and someone gives you this really nice warm jacket. Are you going to say, nah, I'll pass, I'm going to go for a Canada Goose one when that comes my way? You're not going to say that. You're going to take the really warm, really nice jacket that's going to keep you warm. And so, you know, think of the vaccines in the same way. They're all exceptionally efficacious in protecting you against really bad outcomes of COVID.
So I think when it comes to the conversation about the best vaccine, it's the one you get access to first. And that's kind of the moral of the story. And that's how we should probably be thinking of it.
Very good. So anyone else? That might be very.
I can maybe add to that. I mean, I think so the one that you get access to will also depend on the modality of access. So typically at the vaccination clinics, we're administering Pfizer. And typically when we're going out to congregate settings for ease of transportation, we're usually using Moderna, sometimes Pfizer. And then as we know, there's AstraZeneca available in the pharmacies. And so it's really just dependent on the modality. But to just echo all the comments that were made, you should get the vaccine when that vaccine is available for you. And there's no opportunity to come to a clinic or to a setting and say, I'd like this vaccine. We're not at that place. And any vaccine right now is a good vaccine.
Very good. Well, and I'm just, those of you who just joined, you're joining us, Faisal Hassan, NDP, and we are talking a town hall meeting on vaccinations. And tonight we have distinguished guests, doctors, experts, a great panel to be really, we are also honored to have them here tonight to answer your questions. And I know some of you have already have questions on Facebook. I will come to you, but first we have to finish those questions that have already, folks who have already registered as a priority. So the next question comes from Julianne. I'm a personal support worker, but I developed this fear with the vaccine, as I heard so many negative reactions in regards to the vaccine. How safe is the vaccine? Anyone can take that?
I guess I'll start, and other people may choose to join as well. So what I can tell you is the vaccines are very safe. Okay, so all of the vaccines that are currently available in Canada went through what are called phase 1, 2, 3, which are the required studies for any medications or vaccinations to be approved for use in Canada. In terms of that, they look at safety and they look at how well it works. And after a vaccine is out in the population, we still continue to follow them. So even vaccines that you think are kind of routine, we're still following them. If there are any negative reactions that come out, they're getting reported through our vaccine reporting system, and we're always pivoting and changing if we need to. So in terms of safety, there was some concerns about reactions initially when the first 2 came out, which were Moderna and Pfizer. Now, with any vaccine, we typically see anaphylaxis to them happening about 1 in a million. With these vaccines, we're seeing somewhere between 2 to 5 per million doses. So keep that in mind. 2 to 5 per 1 million doses. If you get COVID, there's, your chances of having a very negative outcome or dying are actually much higher. It's more like talking about 2 to 3 per 100 if you are infected with this. So very different. And we always look at risks and benefits. So the risk of a severe reaction is extremely low versus your benefit for not dying, not getting severe COVID, not being hospitalized are very high in terms of the benefit of avoiding those outcomes. So risks are very low. And we're constantly following and we're constantly monitoring. If anything does happen, there are ways to, you're being monitored initially and we're watching you. And then if afterwards anything happens, like there's common things like sore arm, feeling a little bit under the weather, those are just typical with any vaccine. And so those will happen. And that's just your immune system jumping in, trying to get all those antibodies made. So that's just your immune system saying, hey, we're working. I don't want you to run a marathon. I want your body, all the energy to be focused on making an immune response. And that's what happens. People sometimes think it's them getting the illness, but it's not. And none of the vaccines are live, so you will never get the infection from any of the vaccines available. So yes, they are safe. If you feel comfortable, please continue and have further discussions if you wish, but I can tell you that they are safe and you can proceed to get them if safety was your concern.
Very good. Anyone to add that? Or let's go ahead, Akwatu.
I just want to add one point to that. It comes from a study in Ottawa, clinical evaluative science. I forget the name of I think it was Gutman et al. Who wrote the study of immigrant women working in the healthcare, various from nursing aides to PSWs. And what they found was that women of Nigerian, Jamaican, and Filipino background doing the same job as their white peers, but suffering differentially in terms of positivity and hospitalization rates, sometimes 3.5 times that of their peers, precisely because of these other factors, the social determinants factors. This means really nothing to do with you, but the life that you have to live, the work that you have to do, the way that you have to do it, your non-racialized peers, which means you have to do more to protect yourself in terms of prevention, and the vaccine is just one of a set of tools, prevention tools, that you need to weigh against the risks that you are experiencing because of the job that you do. And that's a very recent study, November 2020. So we're looking at real risk in current time scenarios.
Thank you. Well,
Can I just add one really quick thing to that? I also want to say that I think that, what is really great is that we've had such an incredible rollout across the world. And as of last week, we have given 160 million plus doses globally, right? That's 160 million. And so, the great part about that is that because we've given so many doses, we're watching, we're doing due diligence. If there's even the slightest safety signal, we're, right away, we are, looking at it and making sure there's nothing to it. And you can see that's happened even with the AstraZeneca vaccine. I think a lot of people initially were like, what is this all about? But really, that is your example that the second even the slightest signal came to be for safety, everything was stopped. We did a full investigation, and all the governments, all the health agencies collaborated to do this. So we saw this in real time, right? And we've already given 160 million plus doses, and we've got all this great data on safety as well. So I think that should be very reassuring as well for Canadians, given that, the one advantage of having a slightly lower vaccine rollout is that we're getting this amazing data across the world that we can use.
And I agree with colleagues who have spoken before, and because of the sort of the fact that there aren't many cons to getting the vaccine, because the side effects are so mild, and it's not really a question of do you want to get the vaccine or not, it's do you want to get COVID-19 or not. And that's really what we're trying to frame the conversation as, because the downstream effects of getting COVID-19, particularly with the kind of variants we are seeing in the community as of today, for example, means more sickness, more hospitalization, and much more death, actually. That's the real question we're asking ourselves in these discussions. So I thought that might frame things as well.
Maybe just add to that as well. So again, just having, we've been running these clinics here at Humber since the middle of December. vaccinating roughly 700 people per day. And I can just tell you from the reports that we get, we might see maybe one anaphylactic reaction, hives or some other kind of allergic reaction, maybe every third day. So very, very low given how many people we're vaccinating and the sort of thing that a Benadryl or an EpiPen will handle. So really from what we're seeing on the ground, we're not seeing reactions. So it's very, very safe. We've vaccinated many, many PSWs who have come from long-term care and other sectors. So please, please come and get vaccinated.
Very good. We continue the questions Margarita asks. She has two questions, but I'll maybe put to you both questions at the same time. And the first question says, should residents of Toronto wait for a specific vaccine or book an appointment for whichever vaccine is available? That's the first question. The second continuation of that question is, reports with CBC state that the science table is urging the government to not wait more than 21 days to 28 days for the second dose. Currently, we are at 119-day wait. Do you believe that if we wait more than 28 days per dose, that the vaccine is not effective? So that is a question for Margarita. So any one of you can answer that.
Yeah, I can start. I think the first part of the question we discussed earlier, that really shouldn't wait for a particular vaccine because they're all effective. They all prevent severe disease and hospitalization, and they're all safe. Now, in terms of the second part, remind me of the second part of the question again.
And the second question is that the reports with the CBC state that the science table is urging the government to not wait more than the 21 to 28 days for the second dose. Currently, we are at 119 days wait. Do you believe that if we wait more than 28 days for the second dose, that the vaccine is not effective?
Well, actually, studies, and that's a good question because of the sometimes there are issues in getting vaccine doses. Individuals have to wait a bit longer, and I think Canada has been really prudent and really careful in recommending, at least initially, that you should follow the timing that the clinical trials followed in terms of 21 days or 28 days. AstraZeneca actually went to 12 weeks. And I think Canada was very prudent at first, but you should follow the science and you should follow what the clinical trials say. But once the vaccine has been rolled out to millions and millions of people, and in other countries where they've seen that you can extend the timing between the first and second dose and still get a good response, and also people are protected during that period. All of the vaccines seem to be very, very well protective during that difference between the first and second dose. Maybe not as protective in terms of 95%, but one dose can still protect you from severe COVID and hospitalization. And the science tells us that there's not a real issue in terms of getting a strong immune response by extending that period beyond 21 days and 28 days. Sometimes clinical studies are done so that we can get information about whether the vaccine works or not as quickly as possible. But we know from the immune system that you can extend that period. And I think data coming from studies across the world are telling us that, yeah, you have that flexibility to extend without risking contracting COVID, and also without risking having a lower immune response to the vaccine.
Very good. Anyone to jump in that?
Yep. I could probably add a
Sabina?
couple more comments. I think that the way I look at it is that there's two important concepts here that I just want people to think about. First of all, when you're looking at making recommendations, you look at the totality of evidence, right? And so as Dr. Burt said, we have really good data coming from real world, basically when you've given the vaccine out to your population, what it looks like. We also know from our lab-based studies that, we have good antibodies even up until the 3-month mark. And I know people say that, well, we have data until 3 months, but we don't have it until 4 months. So why 4 months? And the reason here is that with antibodies, when you have them in your body, they don't basically fall off a cliff. They have a very stepwise decline in them, right? So you don't go from 100 to 0 right away. So I think it's very realistic to assume that at 4 months, you would still have a fairly good amount of antibodies protection as well. And of course, there's not just antibodies, we're also looking at T cells, which is another part of your immune system that kind of kicks into action. So there's that. And then there's also parameters such as, what is the status of our vaccine stock? What is our epi data looking like, i.e. what is the variance looking like? And we know now in Ontario that 60%, close to 60% of our cases are variants, right? And so that's the first thing. The second thing you're looking at is taking a harm reduction lens, right? So making sure that what can we do, looking at all of this evidence to make sure that we're protecting people, protecting the most vulnerable people in our communities? What are we doing to make sure that we have hospital, ICU especially capacity? We know we're building field hospitals right now, right? And so looking at this entire picture, what can we do to make sure that the most number of Canadians are protected? And in an ideal situation, perhaps you wouldn't have needed to do that. Perhaps you would have stuck with the schedule the way it is in the label. But a pandemic is never an ideal situation. There's nothing ideal about being in a global pandemic, right? And so, what we need to do is making sure that we're actually protecting as many people, because we've already seen, incredible amounts of deaths, incredible amounts of long haul COVID. We just don't want to see any more of that. And how do we protect people? This is one way that we could do it. So that really is the rationale for it.
Well, thank you for joining us. Sorry, Dr.
I was going to make one last comment on this. I know some people have gotten very concerned about changing, when vaccines are giving. Is this something abnormal? And I just want to point out that, as we talked about this kind of surveillance that we do in terms of all the vaccines that are given, we sometimes go back and actually change how we give vaccines. For example, your tetanus shot typically now is given every 10 years. In the past, we actually used to try to give it a bit sooner, but we noticed people had more side effects and you didn't actually have that much more of an immune response. So they were able to spread it out so that you had less side effects from having the vaccine too often, but still maintain your immunity. So we often do that. We go back, we added an extra dose of one vaccine. We actually took out a dose of another vaccine because we found that you were still getting the good immune response you need. So sometimes changing of how we give vaccines in terms of timing does happen generally over time in response to what's happening in our communities. So that's also not something that is only seen here. It's something that's actually iteratively done through our vaccine schedule. And if you look at a vaccine schedule from 20 years ago, it's very different from what it is now.
Well, thank
that
you.
is such a great point, and actually I've learned so much from you, so thank you for that. I love that. What I also wanted to, it just triggered my memory, is the one thing that I've heard a lot is that why are people flip-flopping? Why are our scientists and our health, government, etc., why are we flip-flopping? And I just want to explain that, while it comes across to the public that health researchers, etc., are flip-flopping, it's really just that policy is trying to catch up with the science. And we're in such an incredible, innovative space where there's so much collaboration. We're getting all this science happening so much faster. And what's really happening is that policy and everything is sort of playing catch up to the science, but it's all based on science and evidence that is coming up. It's just that, we're making these decisions as the science becomes available. So it looks like it's being flip-flopping, but it's not. It's all grounded in evidence. And I think that should give people a lot of confidence that we're moving with science.
Well, thank you. I think we've got a lot of comments and a lot of questions. Folks who are joining us live Facebook, I will make sure that we read your comments and questions. Those who have registered we have only 2 more questions, and we'll get to them quickly. The next question comes from Brandon. The media is saying that the Oxford AstraZeneca vaccine is not safe to take it because blood clots and death. Do you think that the federal government should suspend the Oxford AstraZeneca vaccine in Canada?
This is the one we were waiting for.
If that's a very good question.
It is a fair question. I think Sabina does a great explanation of this.
And if I want to be put on the spot when we have folks from the science table over here, because I really like the science table report that came out today. I thought it did a really good job of explaining. So I'm going to let someone else start with it first, and then I can,
Who's going to answer that question?
I'll start, and then we can kind of all join in.
Okay.
So, you know, there is a great, I want to encourage everyone, like actually, as Sabina said, there's a great document that just came out from the science table targeted towards just the general public about this. So like we said, we're always following for any adverse events or anything that happens that is not kind of untoward after a vaccine. And so, yes, there were some episodes that were seen of clots after the AstraZeneca vaccine. And then the key is really to look, okay, how many of these doses have been given? Has this been an increased risk that we think that this vaccine is putting people more at risk of danger than we are seeing of the protection? And so all the different countries will look at all this data. The thing about this vaccine has actually been given, I think, in England the longest. So they have millions and millions of people. So we're able to look at that data. And right now, actually, I have to say all the countries are really sharing their data very readily so that we can look at all of this together. And when you look at it with all the different countries, looking at the evidence, it did not show such an increased risk for people who had clots before who had AstraZeneca, or that there was such an increased signal that they didn't feel it was safe anymore to provide this vaccine. If there was such a signal, trust me, they would shut it down. Okay, so that, and they're constant, and everyone's keeping an eye on it. Everyone is watching to see, do we need to change? Do we need to pivot? But looking at all the data, even though we haven't given many doses here in Canada, other countries have given millions of doses of it. So they're able to get that information. And based on the review, it has not shown an increased risk, but we're constantly monitoring, we're letting people know about it and things to look out for so they can identify it quickly and get themselves to care. So I don't know if anyone else wants to kind of comment on it as well. I think this is actually just really showing us how our systems work, really.
Very good.
I would agree that it really does show us that our systems are in place. I think that is really one of the things that for me, I know people are afraid when they hear about it, but for me, the way I look at it is that our due diligence, our fail-safes, they're all working, and that's exceptional, right, that we're doing this. I think that what I also just wanted to quickly add is just the risk of blood clots with COVID infections themselves are really, really high. So especially, you know, if you're hospitalized with COVID, you have such an incredibly high risk. So 1 in 5, if you're hospitalized with COVID, you have 1 in 5 risk of having a serious blood clot due to a COVID infection. So the risk of actual blood clots with getting the infection is so much more higher. So I think, you know, when we're looking at this, as Dr. Abdurrahman had said, it's all about a risk-benefit analysis. And, you know, over here, you know, the risks of actually having blood clots with COVID-19 infections is something that we should also keep in mind and put things in perspective too.
Can I just add a point to that? People have mentioned at least twice now the science table. The science table is an excellent source of information. It's covidsciencetable.ca. They make a point of writing these science briefs in a very user-friendly way. And I'd highly encourage people to look there, get the latest evidence, but in a way that's easily understandable by the average person.
Yeah, it's definitely one of the stops I make on a daily basis for sure. So thank you to my colleagues on this panel who contribute to it daily. I will say that you know, in some of the popular writing and media and some of the analysis that's coming out about AstraZeneca, it seems to be fair to the question, it seems to have been a public relations kind of blunder, to be honest. And there are some serious questions happening about the company that produced it and how could they have made these mistakes. And we're even seeing some journalists like change their headlines because it doesn't mean we're not encouraging people to take the vaccine, but there is criticism of the rollout from the company, and it seems to be a public relations issue. It's unfortunate that it's leading us down this road, but even more reasons for us to have this discussion.
Well, thank you. Before I go into the comments and the questions and people who are joining us live, the last question from people who have already registered comes from Lenny. And there is a lot of discussion about the efficiency rates in the media. Can you explain how those numbers are arrived at? Is a vaccine with 93% efficiency really 30% better than the vaccine with 65% efficiency?
It's a David question.
Yeah, anyone?
Okay, yes. Those numbers in terms of efficacy are based on the data coming from the clinical study. And the clinical studies are done in a way that half of the individuals are given the vaccine and half are given the placebo, or sometimes another vaccine that's already been licensed. And after they receive the vaccine, and one of the benefits of being able to do a clinical study in this time is because the virus is circulating, so we can actually get a good idea as to how effective these vaccines are. And so the math is quite simple. After a certain amount of time after vaccination with placebo or the vaccine, you see how many people have contracted COVID, and you compare the number who have COVID in the placebo group with those who have COVID in the vaccine group, and then you can work out a percentage of efficacy. And I think the questioner was asking, is 95% really 95%? And just going back to what we discussed already, in the real world now, there's some really good data about how effective these vaccines are. And some really nice studies have come out of Israel, where most of the population have been vaccinated. And I think they had the Pfizer vaccine. And in the clinical studies, Pfizer was 95% effective. And in real life, after millions of individuals have received the vaccine, they've found that the Pfizer vaccine is 97% effective. So the efficacy in a clinical study and the effectiveness in real life is really the same. So it tells you that the vaccines are working. But again, vaccines, we shouldn't be caught up with the number, 95% or 70%. The most important thing is, does the vaccine protect you against having a severe case of COVID and being hospitalized and ending up on a ventilator? And all of the vaccines will do that. So we don't need to worry about the exact number, but that Israeli study tells us that the vaccines are really working well in the real world, and that's really comforting, because you know, it enables us to trust in the science, because it's being replicated in the real world.
I could add to that. I know specifically, and also they wanted to know, what is 90 versus 60? What is 90 versus 79? And these numbers, I think right now we are spoiled. We are talking about 94, 95%. And, you know, this is talking about getting COVID of any kind. We're talking about very mild, we're talking about severe. This is just any kind. And it depends also in the study if they swabbed everybody generally, or if they only swabbed you if you had symptoms. So that also can make a difference. So, you know, when you look at something like if you started comparing our flu shot, you might say, wow, our flu shot only is about 60% effective. But that's also includes all these people who get the flu who may have very mild instances. But what we're trying to reduce is people getting hospitalized and people dying from the flu. And then when you look at that, the numbers are quite high for that. Similarly for the COVID, for all four, whether it'll say 95 or 65 or whatever to start, they're all close to 100% in terms of reducing death, severe illness, and hospitalization. And those are the numbers. If you want to hang your hat on a number, I would look at those numbers. Because if you get COVID and it's just swabbed in your nose, but you didn't show any symptoms, you know, do you want to hang your hat on including that person? Or do you want to look at the ones that are really going to make a difference in terms of our population, in terms of death and dying? Because, you know, you could further stratify the data. Trust me, I have a master's in statistics. I could stratify and we could say, looking just at 90-year-olds, look at how great it is in terms of reducing this, and then look at like, you know, 60-year-olds. But we're really looking at, let's look at specifically the things that matter, which is death, severe disease, and hospitalization. Because unfortunately, once you get hospitalized, your chances of recovering drop dramatically. So our goal is to try to stop everybody from getting disease that is severe and can lead to this kind of next step, because we quote chances of dying, and that's a general. Once you get hospitalized, it goes from like, you know, 2 to 3% to quite high. Sometimes it's, you know, up to 50%, depending once you factor in age, or even higher. So let's focus on the number. If you want to focus on numbers, focus on that reduction in death, severe disease, and hospitalization, of which all of them are about 100%. So all of them are all similar in that. So hang your hat on those numbers.
Very good. And I know that the question of equity is very important in my community here in New York Southwestern. As you read the Toronto Star's report about Vaccine Desert, here in our community, we don't even have a permanent location for vaccines. We have had some good news with regards to mobile through the Humber River Hospital, but I think that in equity, could anyone speak the importance of places like Northwest and Northwestern, where we have identified as high risk and hotspots. Even during the COVID testing facilities, it was September 28, you know, when we had a permanent testing location. So let's talk about why is it important to deal with these disparities and inequities to brought communities like my community to have vaccine more locations in our community.
I could maybe start and try to address that. So part of my interest in joining today was, you know, this idea of this region being a vaccine desert. I take a little exception to that. By that, I mean, as I said, we have been vaccinating in this community from middle of December, about a week after we were told we were going to be getting vaccines. I think when we think about this area being a vaccine desert, I think the point is that this is a COVID hotspot. We need more vaccine allocated to us than we are currently getting. Humber River Hospital, in partnership with our community partners, we are ready, willing, and able to vaccinate this entire community. We see that as our mission and as our goal. We need the vaccines to do that. And that is the challenge. But we are committed to a variety of different modalities. We will come to you, and we have been doing this. One of the things I'm particularly proud of, and Hassan, I think that's where you met up with one of my colleagues, Ruben, we started to vaccinate faith communities. So communities that naturally come together for faith purposes, we are starting to vaccinate those communities as well. Trusted leaders, trusted colleagues coming together to be vaccinated. So we are ready, willing, and able. We just need more supply.
Absolutely. And I say to that, I have also met Ruby, who has been very helpful, and my office has been working with him to actually carry on and also use our office to actually reach more communities to make sure that it has to be done. But you're right, we need more resources, and definitely I have to be able to advocate that, but we need this government to also understand the importance of where communities like this and similar communities like ours need more assistance and support with regards to vaccinations.
And I think, Sudha, to your point, I think when people are talking about equity and there's sort of a critical lens on the rollout, I don't think people are focused on people like you, Sudha, to be honest, in the work you do. I think it's really focused on our governments and the big picture kind of rollout. And I think of two kind of lenses. One is like, there should be no vaccine deserts. And I know we're using that term sort of very loosely here, but if the plan from the province was a pharmacy-led plan, you would have thought that prior to rollout, somebody somewhere would have at least put little pins on a map. You can do this digitally now, and had looked, are there any spots where there are like deserts? And lo and behold, where the deserts were the hardest hit communities. And that is the most unfortunate thing about this. And it is an example of, healthcare racism, frankly, and systemic racism at its finest. That's if pharmacies were going to be core to the rollout. Had we included primary care and family doctors and other, primary care community health models, we probably wouldn't have had vaccine deserts, but that's one conversation. Then, provincially in Ontario, thinking about, about the rollout being, it's kind of been done on in a way that's delivering the same amounts to various areas in the province on a per capita basis, not necessarily based on need. And when a significant proportion of cases are happening in this riding or Scarborough or Peel, these are areas that should be getting more vaccines because the need is higher, because more essential workers, more low-income racialized people live in these areas. And so that's kind of where we're coming at with this conversation and where equity, herein lies in the discussion.
Absolutely, but also I think to be also fair to the Toronto Star article, what they were referring to is when the pharmacy pilot program, in my community, we only have 8 pharmacy. And that tells you the limitations of a community like ours, whereas our neighboring communities, where it's abandoned, every corner is a pharmacy. And that's where they shipped earlier on those quantities of vaccines. Now, there isn't any at the moment, but with that limited 8 pharmacies compared to our neighborings who have maybe a Northwest 39 and others having hundreds and hundreds of them. I think that's where the problem is, and how are those decisions are made? Because we have abandoned pharmacies in our community here. So that's what I think I will in the time of the also, there are a lot of people who are also making a lot of comments, and I want to take some of their questions quickly. I know that we won't be able to get through all of them because we are on the dot at the moment. Maybe we can take 1 or 2. First person to actually ask the first question is Bob Murphy. And his question says, would anyone on this panel that has had a previous brain bleed, cerebral hemorrhage history take this particular vaccine, AstraZeneca? That's a specific question. Anyone? He's looking for recommendation.
We should probably put the disclaimer out there that none of this is medical advice, and this is a general education session. And I think sometimes when these questions come in quite specifically, can put people on the spot. But maybe if my colleagues can speak to generalities about people who've had strokes and people who are kind of maybe bedbound or more housebound or frail, I wonder if there's data to speak to about that.
Very good.
Yeah, so I mean, I guess a comment, yeah, generally, looking at the data, as we kind of refer to this document from the science table, it really does address, and it talks about people who've had any previous clots, and there hasn't been evidence to say that those with previous clots are at higher risk, because that was one of the things that they looked at to begin with. When you're seeing evidence of clots, they said, okay, let's look at who these people were. Were they people who had previous clots, and this put them at higher risk? And they didn't see that correlation. So they are still looking at it, but they did not see that correlation. If you have concerns like, maybe you have something unique about you and you're not sure, also remember, you're usually part of a team, usually have a family doctor or someone who's treating you for those specific things. Feel free to talk to them as well, you know, because everyone's different, right? Like someone might have a couple of different things where they feel with having these 3 diseases, does that put me at higher risk or does that change anything? This is a great time, you know, especially with virtual care. This could be arranged so that you don't have to go into the clinic. You could speak to your doctor, your specialist, and get to ask them these questions as well. But from the clots perspective, they did not see an increased risk in those with previous clots based on the data that we have at this time.
Well, thank you. And I'll say, Bob Murphy, there you go. Basically, you need to consult with your doctor and get more information directly. And the next question I would like quickly, I know we only have 2 more minutes because we were 3 minutes late early. And Paula asked, this is says actually, it's a comment, this is an exceptional panel of experts gathered to speak to vaccines and vaccine inequities. Thank you, MPP Hassan, for this overdue discussion. So that is thanking for joining us. And Frank also says, my sister is a KP transplant recipient and my brother-in-law was multiple sclerosis and on immune therapies. I'm wondering as to why they were left out of the early vaccination stages. They are also high risk, like the elderly. So that is basically, anyone would like to comment that quickly or maybe Domenico?
Sorry, I just had to unmute myself. I can't speak to exactly why the government of Ontario decided to not prioritize people who've had transplants. I will say, though, that as part of the next phase in the rollout, you know, April, May, and into June, individuals with particular health conditions will get to receive the vaccine. There are a number of health conditions that are listed, and they're kind of ranked, you know, highest risk, high risk, and at risk. I'd really encourage you to go onto the Government of Ontario website, where you can take a look at all the different conditions that are listed. It's very specific. You would need some kind of proof that you have that particular condition in order to be eligible for a vaccine. But stay tuned, because the different vaccination clinics will be soon opening it up to people with specific health conditions. And they're likely to be asking for proof. So every time you make an appointment at, whether it's Humber River, whether it's at the public health sites, make sure that you're reviewing the eligibility criteria, because if you don't meet that criteria, even if you are lucky enough to get an appointment, you will not be vaccinated that day of your appointment.
Well, thank you. I know we are also out of time, but we just take one question just to be fair to folks who've joined us live. Next time, folks, you know, register your questions so we get to it next town hall meetings. The last question, folks, if we didn't really take your questions is because we don't have much time and because of also our panel, also other commitments. So last question, Paula asks, my question is, how much does politics play between the health command table, local public health officers, the government, and recommendations made about this pandemic? Who has the loudest voice, and is our direction the right one? So that will be the last question we'll be taking to our panel tonight. Perhaps you can stick around for the conclusions, but we'll also want to, any one of you could answer that question?
Let me say, I wouldn't answer the question, but I'll comment on the question. I just want to say that, you know, we're building the bus, we're driving the bus and building the bus at the same time. So to be fair, you know, I take the point too that, you know, these equity mistakes, when you make one equity mistake is one thing, but when you make 5 equity mistakes every year, then it's a pattern. So, we give you some space, but 5 equity mistakes, that's come on. But nonetheless, the reality is we are designing the bus and driving the bus at the same time. So we actually can't be, we have to have a little bit of flexibility and minimum trust. Not asking you to, oh, I trust everyone. No, minimum trust that the people who are professionals and trying to do this job all want to do the best job. And it's a very difficult terrain. You have vaccines one week, the next week you find out the vaccine supply is delayed. You have this vaccine that's coming. It's really a confusing situation. It's not straightforward. So, I have to big up the people who are, because I sit at different tables and, we keep driving the health equity agenda and telling people, yeah, we realize you're moving from this textured approach to a much more population-based approach, but that doesn't mean you must forget health equity. In fact, health equity must be paramount always. Because right now we're going to forget about we're talking about 80-year-olds who are most at risk. Well, you're forgetting about 80-year-olds who don't come out, who are not going to come out to these mass immunization clinics. How are you going to get to them? It has to be a priority to get to them. How do you talk to them so that they want the vaccine? My own mom, I was telling the story at a different town hall today. My mom shocked me this week. I said, did you get the vaccine? She lives in Ajax. She said, no, she decided she's not getting the vaccine. She has all the conditions, but she believes, she's following social media. She said, I don't want to get a blood clot and die. It's not just, it's a crazy situation. And you just got to give as much faith as possible, but at the same time, keep driving the messages home. And you have to take, we're all in the same situation. We're all on the same situation, even though we're on different levels of the bus. We're all on the same bus. And the task force is continuing to drive the message that equity is as important as any other principle and has to be considered. And that's it. I mean, we're doing our level best. But I don't think that the people who are making these mistakes are doing the level worst either. And I always want to have that nuance. The way systemic racism works, people don't go to work and say, I want to be a systemic racism today. They go to work and they make decisions the way they've always made decisions. It's just that the decisions are rooted in systemic racism, so it has racializing consequences. And that's why we have to drive this agenda in the way that we're trying to do.
Well, thank you. Domenico? Yeah.
Yes. First of all, I wanted to say that in terms of people with health conditions, the highest, the group with the highest priority are people who have received an organ transplant or stem cell transplant. So you should be starting to open up that eligibility for you in the month of April. In terms of, where the decision-making power lays and where the power is situated, I can't fully address that question, but I do want to say that I have felt the power in community voices. If you take testing, for example, testing desert, if you will, in York Southwestern, and I was on the receiving end of an email from your MPP advocating for the community to have testing in your community much, much stronger. And there was some action taken in that regard. Also, Toronto Public Health conducted community consultations on various equity issues related to COVID and the social determinants of health. And the City of Toronto has been, taking all that into account in developing our equity action plan for COVID-19. So I know that I have felt the power of community voice in moving the discussion within government in certain directions, and I really want to encourage to keep doing that.
Very good.
I think the discussion and the question is really valid. I've appreciated the comments, but just to really give credence to the question, inherently, the health of our communities is predominantly social, and social factors, how we live, learn, and work and play to find them and determine them. And inherently what drives that and inequities between those factors is political. So absolutely the product of what we see and don't see in terms of responses to this pandemic is political. And I think we have learned a lot during this pandemic. I agree with Akwatu that I think the first wave we learned a lot, but did we really implement for the second wave? You know, there should have been many more learned lessons. When you start by the third wave, you're not learning those lessons. It becomes problematic. And I think as we close out this pandemic and we move on, hopefully we will look back at this time and wonder why politicians and politics played so much of a role in what really could have or should have been a public health, evidence-based and science-driven response to COVID-19. And hopefully we can plan for a better future. But yes, to answer the question, for sure, it is political.
Well,
can I just quickly add a comment to that as well? And I completely agree with you, Dr. Dosani. I couldn't possibly agree more. You know, and I think that really, I'm first generation Canadian. I moved to Canada 15 years ago. So, so for me, I feel it as a racialized woman of color. And I think that the reason why, the South Asian Health Network, for instance, came to be is because truly one of my biggest fears is that when the vaccination rollout comes up, it's not going to be equitable, and that my people, my racialized communities are going to be left behind. And I really just want to take that time, to urge everyone who's on this, who's listening to this, please do, whenever you get offered the vaccine, please do get the vaccine. It is genuinely something that I urge and I plead you to do, and that's just coming, straight from the mouth of a racialized woman, because I don't want to see my people being left behind. Period. And that is the reason why I'm here on this call today. That is the reason why we do all our advocacy. It is because, for me, my communities are so important, and I just really want to urge you to get the vaccine when it's offered to you.
Very good. I guess we are come to the end of our time, but I think I will give you an opportunity to conclude your comments before we signed off. Maybe we'll start, Dr. David.
Yes, I don't think I can add to what Sabina said. I think that's why we're all here, because we want to make sure that our community doesn't get further behind than it already is. And I know there's a lot of mistrust in our community, especially related to the vaccines, because of historical issues related to medical injustices and access. But I would say that for this particular pandemic, we all have skin in the game. The scientists, the manufacturers, the regulators, the doctors, the people in government, we all need this vaccine. We all need to get out of pandemic. And I think this should help us to, at least for this particular situation, put some trust in the vaccine and the safety and the efficacy. People like us have been actually developing the vaccine as well. And so I think that there needs to be a recognition that we're all in this together, and let's take the vaccine, move ahead, and we'll try and deal with these inequities as we go. And I think this is a really good platform to really do a deep dive into these inequities and these issues that are happening in our society. But let's not let inequities of the past and even the present prevent us from taking advantage of science and often the miracle of science today that can help us to get a leg up and really help us to move ahead.
Dr. Zainab Abdurrahman.
I echo everything that has already been said. I think one of the things we have to remember is, we are in this together, but also our communities, some of the ways that we work the best to support each other is actually by being able to be in contact with each other, being able to attend gatherings, being able to support each other. Sometimes, that means going into other people's homes, helping a new mom, helping someone who's elderly. That's how our societies have been able to continue to combat these structures of structural racism that we are living and working in. And so this vaccine is going to be our chance for us to take that back, for us to be able to go back to the way our society works well. People want to go to various religious gatherings. They want to go to mosque. They want to go to church. They want to go to temple. People want to be with other people and be able to socialize and help others in their community. And that's, some of the strengths of, our kind of ethnic minorities, our racialized groups. That's how we've really kind of been able to come together. And this vaccine is going to be one of the things we can put into our tools to helping us get back there. So let's not let others go ahead of us because we've been adversely affected. So really take this time, get the information you need, make the right choices, do it for yourself, your family, your community, and really make sure you get the best evidence and know that you're getting the right evidence because there is a lot of noise out there. And I hope that you'll keep attending, information sessions like this so that you can get the distilled evidence to you so that you can make the right decision. Thank you for having me.
And yes, thank you, Dr. Abdurrahman, Zainab Abdurrahman, and Sudha Kutty.
Sure. So thank you so much for having me. This has been a great conversation. The questions have been great and the panelists, just a great dialogue. Just again, encouraging everyone to get vaccinated. You can go to our website at humberriverhrh.ca. We have vaccination spots available for next Friday, lots of space available. Please go, book your appointment and be vaccinated. Thank you.
Thank you. Dr. Akwatu Khenti.
I just want to say that I've been vaccinated. I have responsibilities for my elders. I got a dad with dementia in a home. So the reason I got vaccinated is because I'm his primary caregiver. But my mom is also locked in. She's in her 80s and she also has issues and I have to protect her. So I would urge anyone to think. People don't make decisions based on evidence. And this is not how the brain works, but we have to provide you with the evidence so we don't give people an excuse to make the wrong decision. The brain, it's a like-dislike. And then what the brain does is find the evidence that justifies what you like. And that's how the brain actually works, 0-1 like-dislike. So one of the things that I did when my mom told me this past week, she's there getting the vaccine. We have a formula, the motivational interviewing formula, empathy, provide discrepancy, roll with resistance, but also promote efficacy. And that informs a lot of the work we've been doing on vaccine equity. It actually is the way to go because when someone says, I don't want to take the vaccine, you can't tell them, you're stupid. Why would you say something stupid? It can't be like that. You got to say, I understand where you're coming from. Have you weighed all of the factors, all of the variables? Have you looked at the evidence for the clinical trials to see who was represented or not represented? Have you looked at what happens to people who get COVID? And where are you? Where is your group in that? So all I do is say, think about how decisions are actually made, but also know you actually have to recognize your own value to your family. You have to know that without you, your family would not be better off, they would be worse off. So you have to minimize all the risk, enhance all the protective factors. It has to boil down to that. Your family needs you, your community needs you, and the world needs you. And with that in mind, it really creates a narrow window for the decision making.
Thank you, Sabina.
I just want to say 3 quick things. First of all, our frontline essential workers, racialized communities have already borne the burden of COVID. No more. Get your vaccine. Second of all, if you have more questions, please do speak to someone, in the healthcare community that you trust. Your family doctor, your pharmacist are great places to start if you have further questions. And third of all, I also just want to remind everyone that you do not need an OHIP card or government ID to get your vaccine at any of the mass vaccination sites or any of the hospital sites. So please don't let that be a barrier for you to go get your vaccine. If that is, you don't have to be, you don't need to have any of this to go get your vaccine. And so please do get the first vaccine that you're offered. Please do accept it. And thank you for having me here today.
Thank you. And Domenico?
I'm kind of hearing a bit of a call to action from this session. I've decided that I will get vaccine once I'm eligible, but my mother she's in the wait and see camp. Let's wait and see how other people deal with the vaccine. Let's wait and see if there's any negative impacts of the vaccine. And I think I'm gonna have another conversation with my mom and kind of maybe turn the question around about, do we really wanna wait and see if you get COVID? Do we really wanna wait and see if you end up in the hospital? And for me to reiterate her worth to me and the value of this vaccine. So that's my call to action.
Well, thank you. Finally, Dr. Naheed Dosani.
Yeah, just as a closing thought, we may have all been we may have all weathered the same storm, but we were not in the same boat. Some of us were actually in fancy boats and yachts thriving, while others were in life rafts barely surviving. And I think herein lies the fact that this virus, this pandemic, has disproportionately impacted community members who come from low income backgrounds, racialized people, essential workers, and to the point of many of my colleagues, it behooves us to gather this information and to build confidence in this vaccine, so these communities, we are not further left behind, because this is a race where it's not fair. Communities like this start the race from a place that is further behind already, and it would be so unfortunate if the pandemic happens and we look back and this further perpetuates these inequities. It further perpetuates poverty, and it further perpetuates systemic racism. So I hope tonight we've at least began the building blocks for our conversation to build that confidence, to address vaccine hesitancy, to compassionately address these concerns for a brighter future for everyone. Thank you.
Well, thank you, folks. That comes to an end. I want to thank my guest, the distinguished experts, doctors, and scientists, and thank you for joining us this evening for this very important town hall meeting. I hope the answers you heard tonight have provided some clarity and dispelled any misunderstanding and misconceptions. I will be at Queen's Park next week and will be working hard to ensure York South-Weston is not a vaccination desert. Our community deserves to be treated with dignity and respect, and that starts with providing the resources we need to keep our community safe. Well, friends and neighbors, that's it for us tonight. Thank you for joining us, and goodbye. Thank you. Bye.